Good afternoon, everybody. It's great to see such a great group here, and this is a wonderful event. So I'm going to talk about some of the advanced therapies that we have, and I'm sure a lot of you have heard about these in the past, and I'll just point out a lot of the new things that are changing. This is a technology-driven field, and things are dramatically changing on a pretty regular basis, which is great because that means we have more options for our patients. If we go to the next slide. So first, to overview, I want to talk a little bit about how Parkinson's disease affects the brain so I can set the stage for how surgical therapies work a little bit different, and also what the challenges are in some of the advanced stages of Parkinson's where we would need something other than medications in some cases, and it's not for everybody. Next slide. So Lewy bodies, shown here in this image. If we just click one more time, you'll see a circle around the Lewy body there. This is the characteristic pathology seen in Parkinson's disease, and that little red blob there is an aggregate of protein, something called alpha-synuclein, that builds up in neurons or brain cells and causes demise of dopamine cells specifically in the brain, and that causes the symptoms of Parkinson's disease over time. Go to the next slide. What's important, though, is it actually takes a lot of this to cause any problems. Our brain is fairly resilient, and it takes about 70% of dopamine loss. And this slide we're going to click through and see the animation there. But right down there in substantia nigra, in the bottom is the midbrain, where dopamine cells reside. They deliver dopamine up to the striatum. And if we click again, you'll see the projections of where those dopamine cells go up to the striatum. And over time, when you lose dopamine, essentially the brain circuitry functions differently. Once 70% is lost, if you click again, it basically causes a dysfunction in this area, which causes the symptoms of Parkinson's disease. The great thing about what's left with this, though, is that a lot of this is dependent on dopamine levels. And so replacing dopamine allows us to give benefit back by getting that part of the brain working fairly normally again. And next slide. So over time, the therapeutic window of Parkinson's changes. This is early Parkinson's disease, and this is just kind of a graph of what you would think it looks like over time. And what you can see is if a patient takes their medication at the first time point there, and then 2, 4, 6 hours later, you're looking at the blood levels and kind of what that benefit looks like. And somebody with early Parkinson's disease, you're going to get benefit for about 6 hours or so, pretty much from dose to dose. And then as we advance to the next view here, that's actually what the blood levels of the medication looks like. It's about 90 minutes in and out of our system. Well, why such a discrepancy? It's actually because the brain recycles dopamine and allows you to buffer the effects of it so that you don't need to take it every 90 minutes. But what happens as we go next to see here in moderate stage and now in more advanced stage in the next slide, Parkinson's disease, that response changes to look more like what happens in the blood. And so you no longer, you get a good response to medication, it still works. And I think that's an important misconception, is you don't lose a response to the medication if you get a good response, typically in Parkinson's disease. But it changes purely because the brain's not able to recycle it as much. And so we're dependent on different ways of keeping that dopamine stimulation steady. Next slide. And so with deep brain stimulation, one of the major surgical therapies we have, we can use the same diagram here to explain. If we click to the next slide, or the next click, okay. It's animated. Yeah, there you go. If you put a pacemaker wire in there instead of medication, that pacemaker can then pace that abnormal circuit and make it work normally again. And so in the same way, and the important thing here again is that you're not losing function from Parkinson's. The rest of the brain is working fairly normally. It just needs the basal ganglia, or those deep structures of the brain, to not interfere with the normal behavior of the rest of the brain. So again, the brain has a lot of resilience to function normally when it can. Next slide. So if you go to the next slide, what we look at with deep brain stimulation in particular, and looking at the original data from some of the clinical trials, is that people that are candidates for these therapies have gotten to the point where their day looks like this. Basically, half the day a patient may be spent off where the medications aren't working. Another quarter of the day may be where your meds are working, but you have dyskinesia or involuntary movement. So the last quarter of the day is where you have good quality time. And so, certainly when things get to this point, then anything that could stabilize us more could have a fairly significant impact, because we can improve off time, and we can maybe improve that on time with troublesome dyskinesia. If you go to the next slide, and that's what DBS does. It basically gives you half your day back if you look at the original study data. So there's a great increase in time in the on state where basically the patients are able to function normally, and also a decrease in on time with troublesome dyskinesia, so you're not having involuntary movements as well. Go to the next slide. And so who's a candidate for something like deep brain stimulation? Somebody with a typical form of Parkinson's disease, what we call idiopathic Parkinson's disease, and we'll click through these, and basically they have originally good response to medication. They're not bothered by any of these specific symptoms that are related to motor function, tremor, stiffness, slow movements, dyskinesia as well, as something that typically improves a lot with DBS, and in different ways, but it's dramatically reduced. And overall, there shouldn't be significant depression or anxiety that haven't been optimized, at least, and there shouldn't be dementia or significant disabling memory problems. Next slide. So in looking at people as candidates for this, we ask ourselves, first of all, is the diagnosis right? Does the person in front of us have Parkinson's disease or idiopathic Parkinson's disease that we would expect to be a candidate for this? And then really importantly is, what are the goals? What is it that this individual is looking to get out of the surgery? And that's very important, I would say, for anything that we do in medicine, but really important, particularly when you get to these particular therapies that deliver a lot of benefits, but it's a complicated disease, and there may be some things that are bothersome because of the Parkinson's disease that the DBS doesn't do, and it's important that we're all on the same page and understand what it can and what it can't do. And so that's why these kind of symptom-based goals are really important to think about. What is it that you can't do that you would think you'd be able to do better, or would like to be able to do it better? And then have medications been used adequately enough? Certainly if there's an easy option, a new medication that we can add, the risk-benefit ratio of changing a medication versus having surgery is going to be quite different, and so there might be another option left that we can still try. Next item there. And then specifically, there's different things that would suggest somebody's a good candidate, not so good of a candidate, somewhere in between, and we look to see how these different things line up for individuals, so we can advise and give you good advice on what your individual benefit and risk would look like. Next slide. So when are the medications not enough? Despite adjustments in the medications, if you're still having early wearing off, fluctuating from dose to dose, so you have downtime where you're losing valuable time of your day and quality of life, fluctuating between on and off. Tremor, in particular, can be sometimes stubborn and doesn't respond as well to the medications as other symptoms. And so that's often a very good reason for DBS, but not the only reason. And you don't even have to have tremor to be a good candidate for DBS, but it's certainly something that responds well and sometimes is stubborn in its response to medication. Troublesome dyskinesia is another good reason for DBS, because it levels out your therapy, basically getting similar benefit throughout the day. Next. And these are realistic expectations. Again, improving the tremor, dyskinesia, the fluctuations, improving slowness, and walking or gait problems are fairly complex in Parkinson's disease, and particularly if there's freezing. So the walking problems and shuffling that responds to medication will typically respond very well to DBS. The walking problems that are more unpredictable freezing, for example, does not respond well to medication, and it doesn't respond well to DBS. And usually we work closely with our physical therapists and take other strategies to prevent falls in those cases, but DBS isn't really the answer for that part. Next slide. And these are the things that DBS does not do. Again, it doesn't improve those on-period freezing or unpredictable freezing. It doesn't improve balance problems, memory, or what we call autonomic dysfunction, so swallowing and bladder function. And some of these things are things that some people, not everybody, experience in more advanced stages of Parkinson's disease and are difficult to treat. So again, really important that what we do is focused on what your goals are as an individual, because that's really what's important as far as getting out of something like this for what you're looking for. Next slide. So the process here at the Cleveland Clinic, we have a pretty well-oiled machine and process where we have people come through for typically a 2-day evaluation. We do testing on and off medications. We score the severity of symptoms, really get a sense for how bad things are, what the medications are doing, what the medications are not doing. So in many ways, it's a very good assessment of just understanding where you are in the stage of Parkinson's disease, and sometimes gives us other ideas about different medication options as well. We do detailed neuropsychological testing, so we test to see where your memory is at and if there's any major issues there. Are there signs of other age-related cognitive problems that are emerging as well that may or may not be related to the Parkinson's disease? Anything that might pose additional risk or might change your long-term outcome, we look carefully at. We have a psychologist that works with you to see if there's any depression or anxiety that needs to be addressed before moving forward. And then we also look at your medical risk, working with our surgical team and team members to see if there's anything in your medical history that we need to treat differently or address before surgery. Next slide. So there's a lot of different targets or actually places in the brain for DBS, for Parkinson's disease, and actually for other surgical therapies as well. The main one that people are probably familiar with is the subthalamic nucleus, STN. There's another target called the globus pallidus, or GPI. And they've been studied and compared. They actually work fairly equivalently, but in very different ways. And some people might be a better candidate for one than another. So these are some of the different really patient-specific things that we can do to optimize or tailor the therapy specifically to somebody's symptoms. The thalamus is another target that's sometimes used. It doesn't affect all the symptoms, but has a robust effect on tremor. And you can go to the next slide. It's just a cartoon from the editorial where there are a lot of studies that were comparing GPI to STN, and a lot of physicians actually thought one was better than the other, and they're really both very, very good targets. Next slide. What is great, and I kind of alluded to this at the beginning of this talk, is because of the evolution of technology, our options are changing basically every day with this. We now have 3 companies that have a lot of technology, a lot of investment in improving the lives of people with Parkinson's disease: Medtronic, Abbott, and Boston Scientific. And they have a lot of different features that we didn't have when this therapy first came on the market, really over 20 years ago. We've been doing deep brain stimulation, so it's really not new. But what we do every day is new because the therapy is changing so rapidly, and for us as clinicians, I have to say the rewarding aspect of seeing the benefit that we can give our patients when we turn it on and see the symptoms dramatically improve, it never gets old either. If you look at the slide, I just want to highlight MRI capabilities. So originally, when you had deep brain stimulation, you can get an MRI anymore, and this is no longer true, that all 3 systems are MRI conditional, which means that you can have an MRI, but your system needs to be checked out. The MRI has to be performed in a certain way to make sure that it's safe. But generally, we can do an MRI for different medical reasons, if you should need one, provided all those checks are done. And the other thing that's really changed is directional stimulation. These systems, when they first came out, I used to talk about the number of different programming options, and back then things were fairly simple because we only had about 12.5 million different programming choices to choose from. And now they've made these devices more complicated, so it makes it harder for us because it's more than 12.5 million. It's many orders of magnitude more because now there's 4 contacts along each lead. We can move the current up and down. We can change the parameters of how it's stimulated. But now the 2 middle leads are actually segmented, and we can push current left, right, forward, and backwards. So we can really move the therapy around electronically, even without, you know, the pacemaker wire. It doesn't move at all. But we can just use the computer to basically shape the way this therapy is delivered in the brain. And this is all after surgery, and this is something that we can do every time we see our patients in clinic. So it's very adjustable and very customizable, and if we don't like the effects we see, we can turn it off and it doesn't do anything, or we can turn it back on, we can turn it up and down, and actually the patients have control as well, because if you have DBS, you have a little controller yourself that you can adjust it as well. And if you don't like the settings your doctor gave you when they last tried to re-optimize, you can always go back to a previous setting that worked well. The third thing on this slide, and I'll show you more about these as well, is that we now have a system that does sensing. And if you think about, we like to compare brain pacemakers like DBS to heart pacemakers that have been around for a while. And heart pacemakers respond to different heart rhythms. They do all kinds of fancy things. The brain pacemaker is a little bit behind on this, but we're getting very close. And now the one system has the ability to actually sense signals from the brain. And with Parkinson's disease, it can sense signals that tell us if your Parkinson's symptoms are bad or mild at that particular moment in time, if you're having dyskinesia or not. There are signals in the brain that actually we can pick up from the device. And the implication of this is right now that gives us a good kind of diary, understanding how your day goes once we've made changes. But in the future, not far away, maybe a year or so, because there's studies ongoing on this right now, the device should be capable of actually automatically adjusting a little bit up and down, depending on how you're feeling, because it can sense that from the system. And if you're having more Parkinson's symptoms, it'll rev up a little bit. If you get a little dyskinesia, it'll rev down a little bit. So more tailoring, which will mean better battery life, probably less side effects and better benefit. Those are the things that we're hoping that may deliver. So it's pretty exciting where this is going. Almost seems like science fiction. Go to the next slide, please. So the directional leads, like I mentioned, we have for all 3 systems. If you go to the next slide, this is an animation. This is actually the Boston Scientific system. And what you're seeing is that little red blob is an animation of what the current effect would look like. So the stimulation, as it moves up and down that wire, and this is just turning it up and down the normal way, but now right here it's showing the effects of using the directional stimulation, where you can actually push the current like off the axis of the lead. And I'll kind of illustrate this. Green blob is actually our target. That's the subthalamic nucleus. And what we're trying to do is get that current to affect just the subthalamic nucleus, just that green part, and not outside of it. And so you can imagine if we have all these abilities, it's just flipping around so you can see it from different angles, but we can optimize that and get it just in the sweet spot and not outside of it where we might get side effects using the directional capabilities. And this is all within the last several years that we've had this kind of technology, and it just keeps changing. Go to the next slide. There are rechargeable systems, so the batteries that aren't rechargeable last somewhere between 3 to 5 years, but the rechargeable systems that we have for 2 of the different companies last 15 years. So you have to recharge them at least once a week or so, but they last for 15 years, and you charge it just by putting something over your chest, like a vest for 15 minutes to an hour or so, and it'll charge up through the skin. So 15 years for a battery is a dramatic improvement. Next slide, please. And the other thing that's really changing is image-guided directional programming. So we now have integrated platforms for our clinicians that takes a patient's own anatomy from their MRI and puts it into our programming interface, so we can now kind of have a better idea and visualize some of these things, what it looks like, what it should look like inside the brain, what kind of effect we're having. And it really gives your programmer better tools so they can really optimize your stimulation for the right settings for you. And this, again, fairly new in just the last couple years. Next slide. You can just see the changes there. Okay, this is also really exciting and kind of changed dramatically with the onset of the COVID pandemic, is that some of the technology advances that were already in process were accelerated, and that's specifically for remote programming. The ability to adjust the stimulator and optimize it when the patient's not in the exam room with a clinician, but actually in the comfort of their own home, sometimes miles and hours away. I'll go to the next slide. And shown here is actually a video and a screen capture. That's me in the office and a patient of mine who shared this with us on the other side. And that's my view from my programming interface, and his device is off for his right arm at this time. And I'm starting to turn it up, and you'll see there is audio, but it doesn't necessarily have to play. What you'll see is as it turns up, his tremor is going to get less and less. And I'm just doing that all from my office in downtown Cleveland, and I don't know where he's, somewhere in some of the suburbs of the area, so far away, at home. And this is something that we've been able to do now for many of our patients. We might bring them into the office for a detailed program, but if we don't like the settings, or if we want to make some progress faster, we can have visits at home like this. And I think there you can see that the tremor, I think, is starting to get better. Okay, and we can go on to the next slide. Brain sensing is highlighted in this video here. Doesn't sound like we have the audio playing through this. I'm going to talk through this cartoon, but basically this is the Medtronic system again, and what you see there is an animation of these deep brain targets and the rhythms that they have, again, that correlate with the Parkinson symptoms. And that kind of graph at the bottom shows these kind of peaks of the different electrical activity that correlate with different symptoms. And again, we're able to use that to detect the state of the system basically at any given time. We can go on to the next slide. And this is the system, and this is what it looks like on our programming interface. Go to the next slide. And like I mentioned before, the ultimate goal is where this might be going to is closed loop stimulation, where we'll actually be able to automatically adjust. And that's not available right now. It's being tested, but it may be in our future. Next slide. Another therapy that we have is MRI guided focused ultrasound. This is a news clip of one of our patients. This is can be done for essential tremor, but also for tremor related to Parkinson's disease. And it is evolving, so there are some other Parkinson's indications, including dyskinesia, that are coming into the market now, and that's about here. So other things to come with this. It's a non-surgical therapy. It's not non-invasive. It's still a procedure on the brain. And what you see here is our neurosurgeons are working with our radiologists, and they have the patient in the MRI scanner. That's Dr. Sean Nagel, who does this with us at the Cleveland Clinic. And basically making a small spot in the brain heat up using ultrasound. And at first, it just causes the tremor to get better. As you go up on it, it creates a permanent lesion in that area and creates tremor improvement. Like you can see there, the patient drew a spiral before and after, and you can see the kind of the dramatic improvement. You can see how steady his hand is there, where it wasn't before. It is a permanent change in the brain, so it's not non-invasive, and you can have side effects like any other surgical procedure, actually, but it doesn't have some of the other risks, like bleeding in the brain and infection and having a device implanted, so it has some advantages, but it's not adjustable like deep brain stimulation, and we do it on one side. It's not for both sides. But this is, really a fantastic other innovation that we have now. We can go to the next slide. And this therapy actually is being investigated for a lot of other neurological diseases because we can use it to selectively open the brain's blood-brain barrier where the brain is protected from other things in our bloodstream. You can selectively open it in one area to allow like a medication for like a tumor or cancer get through to treat just one specific area of the brain. So it's being used in conjunction with other medications and to study delivery really of these other therapies for other conditions and even for Parkinson's disease as well. Next slide. And I'm just going to finish up with a few more things here. Duopa we talked a little bit about is another surgical therapy, so we should include that in our discussion. That's basically a continuous delivery of levodopa through a pump that goes into the stomach, but it gives you continuous medication 18 hours a day, and so that's another great therapy for some of our patients. Next slide. A lot of wearables are coming into this technology, even in conjunction with DBS, being able to use tracking systems that might communicate with our systems, or at least be able to track how symptoms are so we can optimize therapies. Again, another great use of technology. Next slide. And data and artificial intelligence, I think, are also helping to transform a lot of these different areas that are very technology-driven. Next slide. And so looking into the future, it's important to engage in our clinical research and clinical trials, and I just kind of highlight to point you to some of the resources that we have at the Cleveland Clinic, and make sure you check out our research booth outside and find out if there's any clinical trials that might be good for you. We've got studies of exercise, medications, and different aspects of surgical therapies as well. And next slide. And that's all I have. Thank you very much.